I'm up here representing what we do with the pediatric preclinical modeling program, and just to acknowledge my co-leads, Drs. Donna Sanger and Jason Berman. It gives me great pleasure for us to be able to tell you a little bit about what we try to do within the PPMP. But if there's one take-home message, is the preclinical modeling. That's what we try to do. So we know that pediatric cancers is one of cancers that have fairly good survival rates overall. But for those diagnosed with a recurrent tumor or a refractory tumor or relapse tumor or metastatic ones, the survival rates can be very, very low. Not only that, for survivors of treatments, they tend to suffer, prolonged sequence, long-term health impacts from the disease itself or from the toxicities associated with the treatment. So the rationale for personalized treatment in pediatric cancer really stems from two ideas. One is that kids are not just little tiny adults. They have very unique biology. They have very different genetics, and because of the rarity of pediatric cancers, there tends to be more limited information base in terms of their biology and the genetics. So it's the ability to understand specifically the tumors, the specific child's tumor, in terms of what makes it, what drives the tumor, is also allows us the opportunity to find targeted therapies that effectively targets that vulnerability. So the preclinical modeling program is, we have the aims to develop and use preclinical models to identify specific treatments that target the unique makeup of that tumor. And ideally before administering it in the clinical setting. So motivation and mission is to provide equitable access to this technology for all high-risk childhood cancer patients in Canada and aid the delivery of the information to guide treatments in a relevant time frame. So, we're set up in a way that leverages our unique expertise that are located throughout Canada. So I want to acknowledge a number of people here. So if you, outside of this presentation, if you see these names and you want to find out more about it, please approach them. But I also want to acknowledge our PWLE representatives, Stacey Ferran and Sarah Telford, who is also my co-presenter today. Their guidance and voices have been very impactful in terms of helping us plan our way forward. So essentially, our pipeline consists of essentially what is on this chart. A patient is consented, typically, for example, by enrollment to profile. The sample is collected and it goes to pathology and molecular profiling. You get a bunch of information, including genetic drivers and things of that nature. That information then allows us to establish a PDX using viably collected tumor samples. And this is where the preclinical modeling begins. We establish a patient-derived xenografts. The combination of what we choose in terms of the model to use is dependent on how much samples we obtain and how quickly we need to provide the modeling information. This ultimately results in some information that is directly tested on the patient's tumor in one of these models, and ideally providing the results and reporting it back to the molecular tumor board. Then it gets back to the clinic, hopefully guide treatment. So we have a number of models, and we're adding some more. So what I have up here is the gold standard, the mouse model which is really good for expanding the tumors, especially if we're getting very small amounts of sample. We also have the embryonic chicken eggs called CAM model, and we also have lava zebrafish models. The choice between these models really depends on the amount of material that we get as well as the consideration for throughput, whether we need to have more information quickly, or do we have the time to expand tumor before doing the preclinical testing. We recently also added organoid-based culture of the tumors. Essentially, what we try to do is find a way to grow the child's tumor and keep it alive long enough so that we can test directed therapeutics and essentially try to figure out a way to kill the tumor. So I want to go through this one example that we just recently published, and it really helps to highlight the different model systems that we have applied. It was a adolescent that was diagnosed with a very rare and progressive subtle tumor. Subtle tumor was characterized by proteomic analysis to discover that there was an increased expression of an enzyme called SHMT2. SHMT2 is a driver of one carbon metabolism. Importantly, we found that there was a already commonly used therapeutic called sertraline, which is an antidepressant that had a safety profile in kids. So we were able to take a sample of the tumor and model it in directly in the embryonic chicken model and the CAM, as well as also additional samples we were established in the mouse model to allow time for it to expand and harvest those cells to allow additional testing that included larval zebrafish as well as in vitro evidence. So what we found was there was a chemotherapeutic sensitivity to sertraline, and this result was reported back to the molecular tumor board, and it resulted with the patient getting administered this sertraline therapy that allowed for control of or a limited control, but response.
So just to say, Rod recognized that this was going to be a high-risk patient from the outset, and he actually offered enrollment into Profile when the patient was first diagnosed, or at week 12, when he was also found to have that poor necrosis response using his upfront tissue, and the patient and family consented to all the modeling aims and data sharing of Profile. And so we were actually able to have the Profile report back with information prior to his relapse in May of 2025. And so just to say, when any of you who are used to looking at Profile reports, especially for sarcoma, they're busy. There's a lot going on. I think there was highlighted 7 copy number variants. There was a bunch of expression outliers and several highlighted structural variants for this case. And so when you look through these molecular tumor board reports, you have to try to figure out, okay, what makes sense? You know, if this patient does need something different down the road, what would we choose? And so we have this kind of laundry list, which is annotated by our levels of evidence of things. And so for this kid, you know, he had a VEGF A amplification found in his tumor, as well as expression outlier of VEGF A. And that was, you know, thought to be, you know, potential for VEGF VEGF inhibitors, including regorafenib, cabo, which are also, you know, known to have some efficacy within relapsed osteosarcoma. There was a DPYD variant, so there was a deletion in DPYD, which was thought to lead to loss of function of that gene. DPYD is important in the metabolism of 5-FU, so it was thought that this change could increase sensitivity to 5-FU, which is a conventional chemo agent. There was also increased expression. So we have an expression outlier of SLC29A1, which is a gemcitabine transporter, and in other types of sarcoma has been reported to have increased sensitivity to gemcitabine, which is also a drug that we sometimes use in relapsed sarcoma, osteosarcoma. And then finally, there was amplification of aurora kinase A and B, which was thought to potentially be a molecular indicator for future aurora kinase inhibitors. There was other things on the laundry list as well, but those are some of the things we highlighted. And because of the profile enrollment, there was tissue that was sent to Dr. Sanger's lab for expansion in mouse from the time of diagnosis. And then when the patient relapsed, there was also tumor tissue obtained at relapse and implanted in mice to further work up these possibilities as far as therapies.
So the outcome, so after spending some time, so the diagnostic tumor was expanded successfully in Dr. Sanger's lab using the mouse model. And this was represented by confirmation of at least the high expression of the VEGF ligand as well as the VEGFR receptor. And this was subsequently, the tumors were harvested and dissociated and then sent over to Dr. Berman's lab at CHIO to do functional zebrafish modeling. And this was basically they just implant a little bits of the tumor in the zebrafish, and you get administered the prioritized agents to show that the regorafenib targeting the VEGF signaling pathway and the 5-FU targeting the DPYD variant, as well as gemcitabine for the SLC, very long name, transporter, all have showed efficacy in the larval zebrafish model. So where we are right now is, as Rebecca has mentioned, the patient has since relapsed, and the tumor from the relapse sample is currently expanding in the mouse as well. We're hoping to show at the very least that there is a sustained similar molecular findings. Therefore, even the modeling from the first diagnostic tumor may still be applicable as a third line therapy as needed. So I'm going to ask Darren to take us through.
So what tissues are needed for a preclinical modeling program? On the left, you'll see flash freezing, which is common in most hospitals and is used for DNA, RNA, and protein analysis. This is what we don't want. These tumor cells are not living and cannot be used for preclinical modeling. On the right, you will see viable cryopreservation. These are fresh tumor cells and can be collected into media with a cryopreservant. This allows us to grow the tumor in a number of models to expand it and allow for more drug testing. So this is an example of our intake form. Usually it's filled out by a clinician. And I want to draw your attention to the family input section. This was actually brought about by persons with lived experience. And this section is important because often healthcare professionals aren't consistent in this journey. Cancer is a very long journey, and despite our best efforts, sometimes we have different doctors, different nurses, different healthcare professionals. The one thing that does remain consistent is the families. They're through it all. Often parents, caregivers, and even sometimes the patients themselves become their own caseworkers. So they know their process, they know what has worked, they know details of their status. So it's important to get information from them, which could be helpful in determining the best treatment options.
Sarah. So I just want to acknowledge, take time to acknowledge all the people who actually do a lot of the work. They're spread out across different labs.